Hi everyone, welcome today. Today we have the guest Karina, and so she will talk a little bit about I believe it's her master thesis work, which is actually quite fascinating, and I'm actually quite excited to learn more about. So again, we're women in network science and society, so we basically aim to promote people who are working network science. And if you have any, just 1 second to, um, and if you have any interest in network science, please feel free to reach out to anybody in the society. Everyone is super open. So yeah, just feel free to connect with everyone. Karina, I would just briefly do a little bit introduction, although I know her quite well. She's actually a colleague of mine in my current group, so I know a little bit of her current work. So it's actually quite a great opportunity for me to actually learn a little bit about her work before as well. So Karina, before she studied in college in applied mathematics from Northwestern University in Chicago, and then she kind of went on to epidemiology. I suck at reading that name from Emory University in Atlanta. And then she also previously worked as an analyst for Deloitte Consulting. So last year, I think she joined, which is also current my group, is Professor Hasenauer's group at University of Bonn as a PhD student. So yeah, I without further ado, I'll just basically hand it over to you, Karina.
Hi, everyone. Thanks for being here and thanks for that introduction, Nico. I'm going to talk today about the master's thesis that I completed last year at Emory University's Rollins School of Public Health under the guidance of Dr. Samuel Jeunesse. This thesis explored the interplay between responsive individual SARS COVID-19 vaccination decisions and the transmission of SARS-CoV-2 via a network model of disease transmission coupled with a social psychological decision-making model, and then looked into how that interplay could affect the impact of different potential vaccine promotion interventions. Please feel free to stop me at any time if you have questions, just jump in. So I'm going to start by talking, there we go, start by talking about the motivation for this project and giving a little bit of background on the vaccination decision-making literature. A lot of the kind of initial points that I'll raise about vaccination decision-making studies aren't strictly relevant to my thesis, since a lot of ways I was working off of a paper that departs from previous models, but it's interesting background to know what we're not doing and why we're not doing it. So a lot of canonical vaccination decision-making models are rooted in game theory, and they are based around this idea of a two-player vaccination game, which is a variation on the canonical prisoner's dilemma, which I'm sure many of you have heard of, but in case you're not super familiar with the details, I'll just give a quick talk of how this dilemma works. So the premise is that two prisoners, A and B, are suspected of committing a robbery together. They're isolated from each other and they're each urged to confess. Each of them is purely self-interested. They're only concerned with getting the shortest possible prison sentence for themselves. They don't care about the other person. And they each have to decide whether or not to confess without knowing the partner's decision. The police don't have enough evidence to prosecute either one of them on the principal charge of robbery without a confession from at least one person, but they do have sufficient evidence to convict them on the lesser charge without a confession. Both prisoners are fully informed about the consequences of their decisions. If they both confess, they both go to jail for 5 years. If neither confesses, they both go to jail for 1 year for the lesser charge of carrying concealed weapons. And if one of them confesses while the other does not, the person who confesses goes free since they cooperated, but the one who didn't confess goes to jail for 20 years. So if we look at this from the perspective of prisoner A, for example, A doesn't know what B is going to do, but if they know that if B confesses, they're better off confessing rather than staying silent, because that means that they'll go to jail for 5 years rather than 20 years. So that's the top left rather than the bottom left. But they also know that if B remains silent, then they're still better off confessing instead of remaining silent, because that will they'll go to jail for 0 years instead of 1 year. That's the top right instead of the bottom right. So, and B is going to come to the same conclusion. So the solution would seem that it's best for each prisoner to confess, and then they'll land in the top left corner and both go to jail for 5 years. But if you abandon the individual perspective and look at the full quadrant, you can see that overall the best solution is for them both to remain silent. That's the bottom right, and both go to jail for 1 year. So the paradox of this is that the optimizing choice for each individual is not the optimizing choice overall. And the two-player vaccination game is basically a variation on this. There are infinitely many different versions of this game, and the ways in which the players weigh the risks and benefits of vaccination versus infection can be made arbitrarily complex, but this is one simple example. So let's assume that the occurrence of decision-making is prior to the outbreak of the disease, so the transmission hasn't started yet. Information about possible outcomes of infection is provided to all individuals, and all individuals have the same information. They each have to choose either the vaccination strategy or the susceptible non-vaccination strategy. And they're going to be completely rational about this decision and decide entirely based off the payoffs of the different decisions. The vaccine is perfectly effective, so if they do get vaccinated, they have no chance of infection. And each individual who chooses one strategy is going to interact with other individuals who choose different strategies. So if we look at this from the perspective of one individual, if they choose strategy V, the payoff is the cost of the vaccination, CV, and that's regardless of who they interact with. Because they're fully effective, so regardless of whether they interact with another vaccinated or susceptible person, they have no chance of being infected. But if that individual adopts strategy S, there's two possible outcomes depending on whom they interact with. If they pair with an individual who got vaccinated, then their payoff is 0. They're not paying the cost of vaccination, but they're also not paying the cost of infection because that other person took on the cost of vaccination. If they interact with another individual who adopts strategy S, the non-vaccination strategy, their payoff is then the probability of infection for an unvaccinated individual, which depends on the overall vaccine coverage times the cost of that infection. And essentially, what happens overall in the full population depends on the ratio of cost CR, which is the ratio of the cost of vaccination over the cost of infection. If that ratio is greater than the infection probability of vaccine coverage 0, which we'll call pi 0, then choosing the non-vaccination strategy always has a higher payoff in vaccine coverage across the population. It's going to be 0. That's not the interesting scenario. But if the ratio of costs is less than the infection probability of vaccine coverage 0, then this becomes a coexistence game. And you can find a fixed point that we'll call P star, which is the proportion of the population who are going to adopt the vaccination given that particular cost ratio. And there's some math and some assumptions that you can make in order to find an implicit function for P star. And you can show that P star is going to be 1 minus the cost ratios divided by pi P star, so the infection probability at vaccine coverage P star, and that's always going to be less than the herd immunity threshold. So the vaccine coverage level is always going to be suboptimal if individuals are purely driven by self-interest. And we can see that in the visualization here. So that expression per P star has been rearranged. So now the vaccine coverage is at the intersection of the red line, 1 minus P times pi P, and the vaccine the cost ratios, which for example purposes is being shown as 0.3 here. And then this is being shown for an R naught of 2.5. So the herd immunity threshold is 0.6. And you can see as the CR approaches 0, that intersection point, the vaccine coverage level in the population approaches 0.6, the herd immunity threshold, but it never quite gets there for a non-zero vaccination cost. So analogously to the prisoner's dilemma that we saw earlier, in the two-player vaccination game, when individuals are solely self-interested, free-riding logic prevents the population from reaching herd immunity, because the closer you get to herd immunity, the less incentive people have to get vaccinated. But the kind of shortcoming with this framework is that it's assuming a completely rational actor, and that's not consistent with findings from social psychology, and that in reality, people aren't fully rational, and they're also not purely self-interested when it comes to vaccination decisions. And I think, like, all know that in reality, herd immunity can encourage people to get vaccinated rather than deterring them for altruistic reasons. So my thesis aimed to move away from the concept of rational cost-benefit analysis in vaccination decision-making and instead build on two key ideas from social psychology. One is that individuals rely on heuristics or rules of thumb for complex decisions. And the second is that decision-making tends to obey the law of inertia. So choices generally remain stable over time, but are sensitive to small nudges from unfavorable resulting outcomes. And this was used previously in a study by Pabst et al. At Cornell, who looked at annual influenza vaccinations from year to year. And they built a decision-making model that's summarized in the decision tree on the left-hand side of the slide. So basically, in a given year, every member of a population would either vaccinate or not vaccinate. And then in the following year, if they avoided side effects and infection, they would stick to their vaccination choice and make the same decision. But if they lost, if they had a bad side effect, or if they got sick, then they would be nudged to change their behavior in the following year. And then this was coupled with the basic SIR epidemic model that I'm sure we're all familiar with, purely for convenience, since you can solve for the epidemic size analytically with that model. One thing to note here is that this was quite a theoretical applied math model, and it wasn't validated with real data vaccine coverage, but it actually is consistent with empirical data from a cohort study of influenza vaccination decisions in a group of people over a period of 8 years. A study by Walsh et al. Found that respondents had a very high probability of repeating the previous year's vaccination decisions, 85% on average, but they were better characterized as having a stable propensity to repeat the prior year's decision rather than a stable propensity to vaccinate or non-vaccinate, which basically means that if they made one switch, they were more likely to persist in their new behavior than to switch back to what they were doing in the beginning. And a third finding from them was that those who had not vaccinated and then got the flu were more likely to switch to vaccinating in the future. And those who did vaccinate the flu anyway were somewhat less likely to vaccinate in the future. So this kind of illustrates the effect of nudges kind of in real data. So my goal was to apply some of these modeling methods to the case of COVID-19 rather than annual influenza. Please don't try to read all this tiny text on the slide. It's just kind of illustrating all the many, many different vaccination and case events that have happened over the past few years related to COVID. The key issue that we were exploring is that vaccine uptake remains low among many populations despite high vaccine effectiveness. And we were looking at the particular example of the state of Georgia in the USA, which had primary series coverage at around 58% as of mid-2023. And this is partially due to vaccine hesitancy, and encouraging higher vaccine uptake is crucial, but the effects of vaccine promotion interventions can be difficult to predict, since those decisions to whether or not to vaccinate are so complex. So we wanted to adapt those influenza vaccination modeling framework and apply it to a mathematical model of SARS-CoV-2 in order to provide some insight into how vaccine promotion interventions should be formulated and targeted specifically to boost the levels of COVID-19 vaccine coverage. So this meant moving away from the idea of annual cycles, with flu having one vaccine rollout and then one outbreak and then another vaccine rollout and so on, and then instead looking at the sort of day-by-day constant interplay between infections and vaccinations. Also to introduce stochasticity into both the decision-making and the disease transmission process. And finally, and most importantly, to parameterize and calibrate to real-world data with the goal of accurately representing the local COVID-19 epidemic in Georgia for a specific time period from the start of the vaccine rollout to right before the bivalent booster rollout, and really focus on that one particular population with significant gaps in vaccine coverage. Any questions on any of the background before I dive into methods? Okay. So there we go. In order to answer this research question, we built a network-based epidemic model using the Epimodel software platform, which is an open source R package with various tools for simulating and analyzing different mathematical models of infectious disease dynamics. It has built-in capabilities mostly for teaching purposes, and then also allows users to use their tools to build their own models to answer research questions like this one. Most relevant to us, it supports stochastic network models based on the statistical framework of exponential random graph models, or ERGMs. And it has two different extension packages, one for HIV and SDIs, and then one Epimodel COVID, which was used here, which was originally developed to evaluate cruise ship infection control measures early on in the COVID-19 pandemic, and which we adapted here to this use case. I don't know how many people here are familiar with ERGMs, but just and what everyone's background is, but I'll just give a quick overview of these modeling methods. So first of all, why use network models when modeling infectious disease dynamics? And one of the key reasons here is how small changes in individual behavior can have a large impact on network connectivity. And this is really, I think, well illustrated by this one picture on the left hand of the slide. Across the 4 panels, the number of connections per person is the same, but what's changing is the level of concurrency. So the percent of the nodes who have more than one partner, and that's increasing as you go from left to right. And you can see, even though the mean number of edges per person is staying the same, the network connectivity just explodes as you increase the concurrency. And so if you're modeling a disease and you want to account for the ways that the dynamics are impacted by having an ongoing contact process between node A and B that's still going on when node A starts contacting node C, that's where network models can become really useful. And ERGMs are used for network modeling because they can generate reasonable networks based on egocentrically sampled data, which, since you're almost never going to have a full network census, this is a really useful property. And basically, you model the probability of observing a particular graph, lowercase y, on a fixed set of nodes as a function of a vector of model statistics. Those are your targets, for example, the total number of edges, the total number of 3 cycles, etc. The vector of model parameters theta, and a normalizing factor to get it into the probability range. And you can reformulate that in order to express the conditional log odds of a specific tie, conditional on the rest of the network, as a function of the model parameters theta, and then the change in the model statistics when that tie is toggled between 0 and 1. So this is really, in a lot of ways, analogous to logistic regression. In order to estimate those model parameters theta, if all your model terms are dyad independent, then this can be done analytically using the same algorithm as logistic regression. But in many cases, we have dyad dependent terms. So for example, if you wanted to say if A and B and B and C are in contact, then you also want A and C to be in contact. When you have targets like that, it analytically becomes intractable pretty quickly. So you would use Markov chain Monte Carlo network simulation algorithms to estimate theta in that case. And once you have theta, your fitted model describes a probability distribution across all possible networks. So you're not trying to estimate a single network, but a probability distribution that you can then simulate from. And the simulation results, as you simulate multiple times, will be centered on those network statistics that are based on your egocentrically sampled data. Those are cross-sectional networks. If you're interested in how the network changes over time, you can use separable temporal STIRGMs, which is you essentially let the network be time indexed and then look at the evolution from YT to YT plus 1 as the product of 2 different ERGMs, a tie formation and a tie dissolution. So you look at the ties that exist and then look at the probability of each of those ties persisting until the next time step, and then look at the ties that don't exist and look at the probability of those ties forming. And once you have that sort of network process, that can represent the contact process in a epidemic model that's as complex as you want it to be. So this example here is for HIV and showing interdependence between contact behavior, transmission, and CD4 count, just as an example. In this particular case, we wanted to expand EpiModel COVID's network modeling capabilities, use them to explore vaccination decision-making interventions in the context of Georgia in 2021 and 2022. And so the first step was to parameterize and estimate a two-layer network structure with 100,000 nodes to represent Georgia's 10.7 million persons, and with modeled individuals being part of two distinct overlapping contact networks, one for the household and one for the community. Each is working, yes. Okay. And one major and quite unexpected stumbling block that we reached at this phase was the absence of good and recent social mixing data in US settings that includes children. So I think in the sort of pandemic phase, people wanted to get their social contact studies out quickly. And so it was a lot faster to simply include adult participants only, since you can't really give a 2-year-old a contact diary. And then ethical requirements become much more stringent when you have child participants. And so we had data on US children in the pre-pandemic phase and data on US adults in the pandemic phase, and then data from some other countries, and ended up kind of having to take a patchwork of different approaches in order to really estimate these two networks. So for the household network, we really couldn't find enough data to express the target statistics for an ergom. And so instead we assigned nodes to households algorithmically based on 6 rules from US Census data, which was the percent of households with a member under 18, a percent of households with a member in the 18 to 64 range, percent of households with a member over 65, average household size, the assumption that every household with a child needed to also have an adult. And then we said 97.9% of children live with an adult in the 18 to 64 range, which is an assumption based on the finding that 2.1% of US children were living with a grandparent, but not with a parent as of, I think it was 2021. So as an illustration of this, with 100 nodes instead of 100,000, if you start with 100 nodes, assign them ages based on Georgia's age pyramid, and then split them into age groups, child, adult, and elderly. Here, the medium blue are the children, the dark blue are the adults, and the lightest blue are the elderly. And then we split them into households based on those 6 rules. And the numbers don't quite work out here because it's only 100 nodes, but you can see it's we end up with about 80% of households with adults, about 30% with children, and about 30% with elderly persons. And the household structures that we can see here sort of look familiar and reasonable to us. We have adults living alone or with a partner or roommate. We have single parent and 2-parent homes with children, a few multi-generational homes, and then elderly persons living alone or with younger adults or with a partner. And then we specify the household networks so that the households are completely connected and all of the edges are within a single household. For the community network, we did use an ergom based on we parameterized this based on the COVID view study, which was a national probability survey of US households that collected information on social mixing in spring 2021. And then we combined that with pre-COVID polymod data on age mixing that was extrapolated to US settings by the study by Prem et al. To ensure that we have an appropriate degree of assortativity in age mixing. And then this network, over this network, we simulate epidemiological and demographic processes, aging, births, deaths, disease transmission, disease progression, and vaccination. So in terms of the transmission of disease progression, we were using a modified SEIRS framework. Susceptible agents could stochastically transition to the exposed state if there was an edge between them and an infected person, so a discordant contact. The daily probability of infection given a discordant contact would depend on the vaccination status of the susceptible agent, the symptom status of the infectious agent, and whether the contact was household or community level. And then newly infected agents would be stochastically assigned either an asymptomatic or symptomatic clinical pathway, and then a subset of symptomatic agents would be designated for hospitalization. The probabilities of symptoms and hospitalization would both depend on age and vaccination status. And then in the hospitalized state, agents would experience a higher age-specific mortality than in other states. And then upon recovery, agents could stochastically re-enter the susceptible state where they could be reinfected. And the parameters defining this whole process were either drawn from the literature or calibrated, as we'll get to. But the part that is unique to this model is the vaccination decision-making process that was built into the vaccination module. So essentially, every adult node in the model is either willing or unwilling to vaccinate. And they remain in the state that they start in unless something happens to prompt them to change. So the key ideas here are that if you get a particular dose and experience side effects from it, that might make you less likely to get the next dose, so that could cause a transition from willing to unwilling. Similarly, a symptomatic breakthrough infection while fully vaccinated could also cause a transition from willing to unwilling. And then if you're in the unwilling state and the overall hospitalized prevalence in your community crosses 20%, then that could cause someone to consider vaccination for the first time. Or to consider vaccination due to concern about the effects of transmission in their community. And then we also have extra willing to unwilling pathway to cover all other reasons, mostly community level reasons, the effect of news and social media, et cetera, that might cause a willing to unwilling transition. The symptomatic breakthrough infection pathway, the vaccine side effect pathway, and the hospitalization pathway, the probabilities of actually switching your vaccine views after experiencing one of those precipitating events, those were drawn from the literature based on various studies of how likely people were to be vaccine willing after having experienced versus not experienced certain events. The miscellaneous community level factors, those match probabilities were parameters in the calibration process. So at each time step, any willing agent that was not currently symptomatic and hadn't tested positive recently and were currently eligible for the next dose based on their age and vaccination history could stochastically undergo vaccination, which would reduce the risk of disease acquisition, the risk of symptoms, and the risk of hospitalization, and their vaccine immunity would wane over time. This model was calibrated to reported vaccine coverage by age, dose, and month in the state of Georgia. This plot here is showing the results of that calibration process, with the brighter lines being the CDC reported vaccine coverage that we were matching to, and then the shaded areas being the simulation results across 108 simulations. Since there's only 2 free parameters per age group and dose, it was of course impossible to completely match what was reported, but the goal was to get sort of the beginning and the end and the general trend right. We also calibrated the per act infection probability and the age-specific hospitalization proportions and disease-related mortality multiplier, so that the infections in the model matched confirmed case counts adjusted to account for underreporting and scaled to a population of 100,000, and so that the hospitalizations and deaths matched the reported hospitalizations and deaths scaled for the population size. Any questions about methods before I dive into results? right. Whoops. So this plot here shows how the total vaccine doses administered across the 20-month time frame of interest varied as we changed the nudge probabilities associated with the breakthrough willing to unwilling pathway, the miscellaneous willing to unwilling pathway, and the hospitalization related unwilling to willing pathway. So both plots have the hospitalization nudge probability along the x-axis. For the left-hand side, the miscellaneous nudge probability was kept fixed, and the breakthrough nudge probability was reduced from its reference value to 0. And on the right-hand side, the breakthrough nudge probability was fixed, and the miscellaneous nudge probability was reduced from its reference value to 0. Looking at the left-hand side, you can see the breakthrough nudge probability is not having an impact at all. So the contours are completely vertical, and as the hospitalization nudge probability is increasing, so as an unwilling to willing switch is made more likely, the vaccination count is increasing. Looking at the right-hand side, we can see that when the miscellaneous nudge probability is above a certain threshold, we have diagonal contours. So both the miscellaneous nudge probability and the hospitalization nudge probability are having an impact. But as we get lower, there's a region of noise, and then we get a region of just completely horizontal contours. So only the miscellaneous nudge probability is having an impact on the vaccination count. The hospitalization nudge probability is no longer having that impact. And then this carries through from vaccine doses administered to the infections. It's the same kind of pattern, just with a little bit more noise since we're going from the intermediate to the final outcome. So essentially, same idea. When the miscellaneous nudge probability was fixed, incidence is decreasing as the hospitalization nudge probability is increasing. And then simultaneously increasing the hospitalization nudge probability and decreasing the miscellaneous nudge probability is decreasing the incidence if the miscellaneous nudge probability is above about 20% of its reference value. Below that, it's the hospitalization nudge probability is having a negligible impact. And the minimum incidence rate across all these scenarios was a 24.0% reduction compared to the reference rate. Yeah, Echo, did you have a question?
Yeah, so I assume like the slide before you had was like the analysis from the data, I assume, and then the current one is like the model, like the results you actually can mimic on that, right?
Yeah, so this is the reference model that was calibrated to the data. And then from that reference model, we changed these nudge probabilities to sort of test the impact of hypothetical vaccination promotion interventions. So like what would happen if we could make it less likely that someone would vaccinate after someone would stop vaccinating after a breakthrough infection, or make it more likely that someone would start vaccinating after hospitalizations increase locally.
I see, because like it seems like for A2 panels, like it seems like the dynamics are very well captured.
Yeah.
Yeah. Okay.
Yeah.
Because I didn't really understand like the specific dynamics. Like, is it just noise, or like is it just like a special like phenomenon that's happening? Like, for example, in the kind of like a diamond shape part.
You mean in this middle section? Yeah, so because it's a stochastic model, basically what's happening here is that sometimes the hospitalization flag is being, like, sometimes the hospitalization threshold is being crossed and sometimes it's not. And so there's this sort of like here, the hospitalization threshold is always crossed, here it never is. And then in the middle, sometimes it is and sometimes it isn't. So there's this like band of noise that's a little more difficult to interpret. And that's just model stochasticity.
Yeah, it seems so. Yeah, thanks.
Yeah, any other questions? Okay, so I think these dynamics are a little clearer when you start looking at the timing of the different interventions. So in these plots, the blue shaded area is the case curve, the number of infections per day. And colored lines are showing the difference in the cumulative vaccine doses administered in the intervention versus the reference scenario. So the reference scenario is the one that's calibrated to the real data. So looking at panel A, if you just double the hospitalization nudge probability, that's affecting all vaccine-resistant persons who are resistant at the time that the hospitalization threshold is crossed, which is happening in fall 2021 during the Delta wave. And that doubled probability leads to an increased vaccine uptake relative to the reference scenario across all doses starting during that Delta wave period. And that's too late to really affect the Delta peak, but it does lead to a reduction in the Omicron peak. For the breakthrough nudge probability being reduced to 0, that's panel C in the top right. You can see it's acting on a much smaller scale, but it's also starting much later, since it only affects people who are fully vaccinated and have experienced a symptomatic breakthrough infection. And those breakthrough infections are usually happening during Omicron. So the reactions to the breakthrough infections are like only during those last few months when there's very few cases to begin with. And then the miscellaneous nudge probability, which is halved in panel F and reduced to 0 in panel G, it affects all individuals who receive at least 1 dose, and it increases the second, third, and fourth dose uptake, not the first dose. And it does that much sooner, pretty much February 2021, the second month of our time frame, and on a much larger scale. And because it's acting so soon, it can affect both the Delta and the Omicron peaks and reduce them more considerably. And looking at the interplay between hospitalization and miscellaneous nudge probabilities, when the miscellaneous nudge probability is only halved, then we're usually still crossing the hospitalization threshold in fall 2021. So the hospitalization nudge probability being doubled has an additive impact. But if the miscellaneous nudge probability is being reduced to 0, that suppresses the hospitalizations enough in fall 2021 that the hospitalization threshold is never crossed, and so therefore the hospitalization nudge probability, which controls the reaction to the hospitalization threshold being crossed, is no longer relevant. So in terms of what these results actually mean for public health and for vaccine interventions, the key takeaways were that interventions based on community level factors influencing decision making had a greater impact in our model than interventions based on individuals' vaccination or infection history, and that's simply because of their wider reach. So the hospitalization and miscellaneous nudge probabilities, those are the community level interventions, and they pretty much affect everyone who's, for example, everyone who's vaccine unwilling when the hospitalization hospitals near their capacity, not just the people who are hospitalized themselves. And so it has a much wider reach than the breakthrough nudge probability, which only affects people, this much smaller group of people who had, who themselves experienced a symptomatic breakthrough infection. The second key point is about the importance of timing. So the interventions that kind of anticipate a new wave of infection and allow vaccine coverage to build up before that. Those are more impactful than the reactive interventions, simply because if the vaccine coverage is increasing after a particular peak, then naturally that peak is going to be unaffected. And then more generally, that models with greater psychological realism like this one can be useful for informing future public health intervention addressing barriers to vaccination, both in the context of COVID and other vaccine preventable diseases. That is all that I have. Thank you very much for listening, and I'm happy to take any questions.
Thanks, Karina. I would just stop the recording, and I guess